Well, welcome to this episode of The Dental Guys. I'm Wes, the Dental Guy.
I'm John, the Dental Guy.
John, we're in a very special place, broadcasting live from Chicago at the American Academy of Fixed Prosthodontics meeting, and we just heard an amazing lecture from an amazing person.
Dr. Fradeani's here with us, and thank you, first of all, for being with us.
Thank you for asking me to come.
Yes, and thanks to Quintessence as well for sponsoring this broadcast today. So we just heard you speak about, well, a great many things. You talked about how to think differently with an app that you talked about as far as preparing for some of these restorative cases. But I wanted to maybe start the conversation with a topic that I know you're very, very familiar with, which is vertical dimension alteration. And you talked about the old way of thinking about vertical dimension, that maybe people were concerned about that. But it sounds to me that really there's no significant concern based upon the research that you presented.
I mean, it was considered in the past that the rest position was a position that was not alterable in any way. And the rest position is, of course, related to the video, because you should have a freeway space about 2-4 millimeters, you said.
Yep.
But then many people, many researchers, many clinicians also understood that this kind of freeway space was possible to be regenerated. At the same time, you can also understand that if you stay in the morning, maybe you have a minimal one, in the evening, after you stay all day long, you become maybe, not more in great shape at the end of the day. You have a bigger value, like 6, 7. So that's what I extrapolated at the beginning, that could be possible to have this kind of situation in which you can alter the video without creating any problem on the freeway space. Because the first problem was not the speech. Maybe the patient cannot speak. At the same time, many authors now showing that it's possible to alter without any problem. And as I showed, there is the Abduo article that take into account 908 articles in order to see what there is in literature. There is not so much. Most of them are not really scientific scientific articles. But at the same time, we're nice to see that in any case, the final outcome was that up to 5 millimeter anteriorly is possible to increase the video without having any kind of signs, symptoms that can be permanent there for a long time. Within a couple of weeks, they go away. So that is from the article from him. Other problem was the article I showed, so an article by Jeffrey Okeson, showing that if you have a moderate increase of a video, doesn't create any problem on healthy TMJ.
Yep.
And also if you have a wrong TMJ, it means that with alteration, doesn't seem that to create more problem anyway. So at this point I say, what is the goal? The goal, the reason why we want to increase the video is very easy. That to increase the space for your restoration, because you have already patient with a very abraded, eroded dentition, and of course you don't want to use even more your burrs to add the destruction to other destruction. We would like to have the chance to really add volume, and that is the main goal. At this point, the increase of video was done for that reason. What is interesting, in my study that we did with our group, 17% of people were complaining about something, like some sign or some symptoms. But 83% complaining at all, not complaining at all, zero. It means they went out and they don't feel anything wrong. Either the speech, either the chewing efficiency, either the bite forces, nothing. So it means that at this point is quite understandable that most of the patients react in a perfect way. Our numbers are not so good as the group from Israel, like Martin Gross. They showed that was just 5% of people were complaining, even less. So in our study was 17%. Still very low percentage, but 5% even less. So today the literature seems to be quite agree about it.
Yeah.
One of the problem, if I can go ahead.
One
of the problem is also that most of the people, maybe not so many dentists, really understand the mechanism of this, what happened in the alteration of video. even before doing pros. Because when you have the grinding procedure, and you have the attrition, and you have this very short teeth, most of the time there is a compensation phenomenon from the apposition of new bone, from the cement of the roots, creating some extrusion. So until the teeth are still together, grinding each other, they can decrease the height between the teeth, but they increase the height of the bone underneath, keeping the same height between the two arches at the end, more or less.
Interesting.
That's interesting because there is also more than that. Because actually after that, you put maybe some restoration in, so you really put an increased value
Yes.
of video compared to the original one. But then there is also an intrusion phenomenon that happens within 6 months. So that's the reason why some people say that is a complete reintrusion. Other people partially reintruded. Not everybody agree with that.
So
it's quite complicated.
that's interesting.
That
so
is very
you're saying that really the VDO is sort of altering itself during attrition,
Yes.
and then when we are adding restorative material back, that in a way it is kind of
you will increase the video even more.
Yes.
The video reacts.
The video
going
reacts
back.
by compensating back.
Back.
So there is somewhat of the ability of the body to compensate to a VDO position that is.
I'm not sure about this.
Well,
So
we don't know why,
I don't
maybe,
know.
but
I don't know. But one interesting step is also that I know some clinicians that wait 6 months before finalizing the case for that reason. Frankly speaking, I don't do. If I have a case that you have implants or perio that have to wait for months for the healing and maturation of the soft tissue is okay. But if not, I don't see any reason to wait. I don't need to wait.
yeah.
So I don't wait. I don't see anything wrong.
What's your average treatment time that you're going from maybe, mock-up to final?
Yeah, the mock-up to final, normally I transfer this kind of information not after 6 months. I don't wait so much.
Right.
Because, of course, the mock-up, depending what you do with the mock-up. Mock-up can be done as provisional or as just mock-up. If you do as provisional, you have to remove the mock-up and then relining, refining, and cementing. That's normal, regular provisional. That's the case when you print it in the mouth and leave it for a few days just to let the patient understand how it works. That's not cemented. That takes, it can stay for days, not for months.
Yeah, but your timing is not determined by, again, waiting. It's just to get through your procedures. You're not waiting for
Absolutely.
Yeah.
That's what I do. And frankly speaking, maybe it's not the safest procedure. I'm not sure. Because if you really have this kind of rebound within 6 months, maybe you should wait. But having done so many forms of rehabilitation in my life, I never understood something. Even though I know the literature a little bit, but actually I don't feel uncomfortable to go ahead with in
Now you cited when you talked about increasing VDO and that sometimes we see a decrease in attrition and the wear seems to stop. And you did kind of cite early on an article by Guy Levine talking about how weather bruxism and sleep bruxism. Do you think that you mentioned when you increase VDO and you change the occlusal design, that you feel that the difference in that bruxism is because of the different type of chewing force, mastication force? Do you think it has anything to do with airway? Or do you think that it is because you're changing the way that the teeth are functioning?
Difficult to say because you have also articles on the airway that are saying that you have a reduction on bruxing activity over 50%. So that could be a nice question also to ask, not to me, but maybe to the searchers.
Yeah.
But anyway, yes, that can be a combination of situations. But actually, I'm not sure that everybody that are treated by for that reason, for the sleep apnea, are bruxing too. I mean, that's
still controversial, isn't it?
It's difficult to see this kind of combination. Sometimes it happens, most of the time maybe not. What is important also, I believe that I showed an article by Eckfeld on the way how you can regain a new kind of masticatory cycle sharper than the beginning one that was wrong. Once you follow some basic occlusal rules, like I said, mark the contact on posterior, uniform, punctiform, equal intensity, synchronized, and light contact anterior with the anterior guidance. All this stuff, very classic one, but seem to work quite well. Actually, in this study shows that 75% are really immediately well conditioned by the new rules, the new setup on occlusion, and they don't go anymore to the right, to the left, grinding away all the teeth on the right side. That is important because today we have also a lot of instruments that showing how you chewing. Okay, and the understanding of you chewing the number of function that you use it is important to understand what you can do with your final habilitation. At the same time, it's also true. If I see that the chewing efficiency of this patient is the optimal one, when you go to the left, because of still working on the old fashion, it means that when you had the chance to grind all this area on the left side, you follow them, but you don't rehabilitate the patient because the patient will be not ideal aesthetically at all. So is that what you believe that is our goal? I don't think so.
Right.
So I think that we should try anyway to idealize the case. Knowing the chewing cycle is good, but I don't think that you should follow this 100% of the cases. Maybe you should try. In this case, if you have some kind of adaptation of the patient or not, and then you decide. At this point, maybe you can have the chance to use mock-up, but maybe bonded, cemented.
Right. Speak to the mock-up a little bit. One of the things that you spent some time talking about, it's something that John and I have been interested in for many years, is how we take digital photography of our patients, retracted teeth apart, smiles, lip at rest, all these things that are important to communicate to the technician. How are you communicating? You showed some impressive things in there regarding communication to the lab technician and how that leads to a mock-up design on a model as an analog model. What are you using to communicate with your lab technicians?
It's a good topic. We actually launched a couple of years ago our app, okay? And the app is exactly made for that. Because in the app you have the combination between aesthetic and functional parameters. So you follow step by step, for example, all the steps that was here on the aesthetics, plus other, because of course it's something new that we opened, we launched just a couple of years ago. At the same time, we had also the chance to add all the functional parts. Because as I anticipated just briefly here, I believe that it's completely crazy to just rely on the 6 anterior teeth on the screen.
Yes.
What that means?
Right.
What that means is nothing.
Yes.
What about the lowers? They don't care about the lowers.
Right.
Doesn't exist. It's crazy.
Yeah.
I have a function. I don't want to put 6 anterior, then I have a 10 millimeter overbite, or maybe 1 millimeter overjet, or 0.5 overjet.
Yep.
Just put in there on the screen. In our app, you have the content. I can tell you, I can scream that. There is no other in the world on that. We have a content inside.
So it's a communication tool, essentially.
To communication, because we gave it a PDF to the dental technician. You have to invent nothing, just following.
And you're showing envelope of function. I saw there. That's something that's included.
No, that is the envelope of function was we had 3 windows.
Okay.
The first one in the left, looking at the screen, the left was a new kind of instrument that we are trying.
Okay.
I cannot.
Can't talk as much about that. Okay.
That's something
I can talk about my app because it's mine, but I don't want to talk about others.
I understand.
But anyway, the app is great because it combines all the steps. Actually, I tell you the truth. I had very much interest by colossal companies at the beginning. And then they said, oh, you did something great. There is nothing in the market like that. But for the market, it's too much. That's what the answer me.
So
it's too much because it takes 10 minutes maybe. But if you do for Mauro rehabilitation or even 6 anteriors, how many hours, how many days you take?
But you're saying they said it would take too long.
Too long.
Wow.
I take 10 minutes to do the data collection. I take 12 minutes to the data processing.
Well, right now, one of the things that we were taught at Spear Education by facially generated treatment planning was how to take photography, use that as a communication tool, and we went as far to, we were taught to use it in PowerPoint to communicate, you know, a set of slides. And
but this is the next level.
This is next level stuff.
Next level.
Now, what you're saying, is this an app that's available right now for purchase? Is it,
where do people need to go to learn about that?
They just go to Apple Store.
Yeah.
Okay.
It works only on the iPad.
Okay.
And what's the name of the app, just so we can
app,
get app?
like a guided aesthetic treatment app.
Guided aesthetic treatment app.
Guided aesthetic
Get
treatment.
up.
Yeah.
Get up. But actually, I give it, for example, an example. Since the first screenshot, you have the name of the patient and the age. And already inside the app, you have a target. Because if you have a man 70 years old, for example, to exposure at rest, for example, where we start every treatment plan on pros, like incisor position, the most convex area is the two central incisors, have the duty to arrive maybe plus 0.5. That's the goal. For the lady 25 years old, it's 3.5.
Right.
So we start with that. But we have to remember that as soon as they put the name, the age, the app takes it into. So the target is already done.
I want this
so
app.
they already know. So you already know what by age.
I will send you.
Yeah, this is something we need to try because we've played around with a couple of different applications and we see the value in that because it's all about that communication. But to have that all in one is something that, and again, the time, I think we've talked about this with our laboratory because they will say the same thing. They'll say people won't take the time to do this. And
I don't know what happened in the States or in Germany, but I tell you what happened in Italy. Technician decide for the clinician. Clinician don't see the patient, they invent everything, comprehending vertical dimension, comprehending everything. You know what about vertical dimension? I did a survey in my educational center with many groups, okay? I'll tell you, 83% don't say anything about how much increase the vertical dimension.
83%.
No, 83%, no, it's wrong, sorry. 83% say something. So say, how much increase video when you need to increase?
Yeah.
And the answer was, a little bit.
Wow.
MP. Chu-chu in Russian and Chinese. I don't remember, I learned it. Un po' in Italian. What that means? For me, 0.5. For you is 1. For you is 1.5. Another guy is 2 millimeters. Un po'. What that means? And nobody knows and say where. What do you mean where?
Anteriorly versus posteriorly?
Not lower or upper.
Okay.
Why different? I don't ask you, but I want to just explain to the audience if I can.
Yeah.
Somebody can see me. Yes, of course, I can see from the TV. If you increase the video 3 millimeters, 1 millimeter, easy, okay? You see the lower anteriors 1 millimeter longer. If you increase 1 millimeter the upper, you see the upper anteriors 1 millimeter longer. No, because you are here. If you have the overbite, until you don't cover the value of the overbite, you don't see anything longer.
Right.
If you lengthen something, is for other reason, not for the video. 0% say that. So technician, what does invented? They said 3 millimeter, maybe 1.5 each. Like myself, I'm talking now. They can see us from TV. I'm just showing the lowers, age, and also constitutionally, but like that. Okay. So I don't show the upper when I talk. I show just the lower. At rest, I show the lower. See, if I increase even one over the 3 millimeter in the lower, it's already wrong. In my case. But I can see that because I see the patient in front of me.
Yes.
But the
technician cannot see that.
So maybe can do also, but I don't know if they do or don't do. But if they do, maybe they can help it.
But the clinician needs to take the responsibility.
But the connection is the problem, is not the problem. You have to think about that. When you have a guy doing the technician, and do you think they say to us what they think about us?
They don't.
Never.
They don't. Never.
They don't. For one simple reason. Because we pay them.
Right.
And once you are unhappy for that, you say, oh, he's also criticizing me. I change it. And they don't want to have this problem. It's like me and you when you have a patient in front of you. You love every patient in your life? No. I have some that I don't like so much. And last time I was giving a course, and they come to me and say, oh, dental assistant was behind. Doctor, I have to talk to you. What happened? There is Miss X that want to talk to you. I told you I'm not here at all. I don't want to talk to her.
Right.
I don't want to talk to her. But I said, no, sorry, I said that you was here. Geez, now I talk to her. When I went to her, I didn't say, I don't want to talk to you, because you are not nice at all. I said, hi, how you doing?
Right.
Look, you look great. Why? Because they pay me.
Yes.
They're clients in both cases. That's the problem. It's not a normal way. Unfortunately, it's a normal way, but it's a wrong way.
Yeah. It's not a colleague who you can be humble. You have to be able to be humble with, right?
Right. I think the critical conversation we always talk about is as a clinician, letting your lab technician know, I need your feedback.
Yeah.
Right. I need you to tell me, here's what I require. If I don't give that to you, then you need to give it back to me and say, hey, I need what I need. And that style of communication is hard.
But he's already gone, this problem. With the app, I don't want to do advertise for the app. I want to explain. I spend a fortune. I never get back with money. Zero. So, all the master that I give, the courses I give in my educational center, I give it for free. 1 hour of subscription. I cannot give it for free the app because they don't pay me.
Right.
They pay Apple that they don't care about us at all. They take 40%. They decide the price, different in the States, in Italy, in Germany. We don't know why. You call them, they don't care about you at all. They don't answer at all. But all the information are inside the app already, 100%. You don't have to invent. Being a technician, you don't have to invent anything. 0.0 period.
Right.
I'll send you guys.
That would be
passion
excellent.
to try. You can ask my staff. They will help you. You have also in YouTube.
Now, one other thing you talked about was the change in material thickness, and it falls right in with this vertical dimension discussion because one of the ideas behind that vertical dimension increase is reducing the amount of tooth structure that we're removing and remaining in enamel.
In this case, my goal is not touch at all.
Yes.
Right.
Because if you increase 3 millimeter as average, you have 1.5 in the last molar, 0.8 each one. No. 0.8 is the minimum thickness that I believe that is okay. Because if you look exactly what the Ivoclar said, you can say that I said the company and the Congress, but you can say the company I was mentioning was Ivoclar.
Sure.
They say 1.5. Why? They say two options on posterior. 1.5 monolithic, 1.5 bilayered. Do you think it's the same strength?
No.
The strength is what? In what you have underneath, not
right.
over.
But
so 0.8 is already good.
Yes.
That was my speculation at the beginning. I started, and then Petra Guess show in 2 articles. I just show one.
That it was down to 0.5.
Yeah,
even.
exactly. I use less than 0.8. I'm collecting 3,000 restorations with the thickness measurements. And we have average of the last 25 big rehabilitation is average about 0.4.
So let's be sure.
But in enamel.
And you're talking about, again, lithium disilicate, not zirconia.
Yeah.
Right. Lithium disilicate down to 0.4, and you're seeing equal success.
With the tabletop, sure. With the tabletop, yes.
That's a game changer.
This is a game changer.
That's a game
because
changer.
what you're saying is we used to do crown lengthening. We used to do all these things to achieve the results that we root canals and post.
A
and
lot
cores,
of devitalization of teeth.
And you coined this term of MIPP.
Yeah.
Right?
Minimally invasive prosthodontic procedures.
Right.
Which is what we're talking about. If you can buy an extra millimeter of restorative material ×2 for an upper and a lower, say, if you're doing lithium disilicate, that is a tremendous amount of that we're not having to do to the tooth. And the material is holding up.
Exactly what they do. I normally just refine the occlusal. I mean, I precise at a certain point. If you have dentin, it's not a story. If you have dentin, I don't trust dentin as enamel.
Yes.
Right.
So if I have a dentin, I stay to regular numbers.
Yes.
Maybe not 1.5 because I don't really like to kill completely the tooth. But maybe 1.2. But if I have an enamel, change the story completely.
Yes. And you're able to take advantage of bonding.
Yeah,
and,
of course.
And that's what you're using to be able to ensure the strength. And Ivoclar is changing now. They're changing their recommendations to 1.
You know how many times I said you have to reduce. To reduce is wrong. It's wrong what you say. And now they did it.
Yeah. So do you think that they'll continue
I didn't talk to them. I talked to them many times in the past, but not
But
recently.
I think, John, the thing that's interesting here is if we're talking about single tooth dentistry and we're talking about lithium disilicate And if you go out and you tell the budding clinician that doesn't have maybe the education or maybe the knowledge yet, right?
To know how
Some
to
of our
prepare the
listeners
tooth.
might be in school, and you're saying, oh, we can prep now a single tooth, you know, number 19, the most crowned tooth in the mouth, you know, lower first molar, upper first molar, and only reduce 1 millimeter on the occlusal table and this minimally invasive prep 360 degrees. I think we have to be very careful to clarify what we're looking at here and the knowledge.
Because the type of preparations are, it's not the same preparation design as what we were taught.
No, the company said to me that, of course, they were afraid to say that because they believe that not everybody are really following the same rules.
That's right. That's the rules we want. And speak to the.
They're afraid about that. Yeah, understandable. But if you do well, you know, if you are conscious that what you have to do, I believe that is really working very well. One problem is maybe the most important problem is the technician. Because with a very thin layer, I have incredible super result. I'll tell you the truth. I feel very confident with my technician, but I believe with this very thin thickness will be not easy for technician to handle.
Yes.
Are you milling or are you pressing?
Pressing.
Yeah, you would have to for most of these, correct?
Right, because
with that minimum
you can't
thickness.
mill that thin.
All the companies try to push you to use milling.
Yes,
because they connect each other. They want to earn it, of course. But frankly speaking, if you talk to the practitioner and the technician, they love to use pressing, especially because the thickness is reduced.
Yes.
It also working faster. They don't need to buy something in the office. They do the press. They have in their own lab. In the other case, maybe you have to send outside for the copying.
Well, and usually, too, if they mill, we're finding that they're milling to 0.6, 0.7, then having to hand finish. So it takes them a lot more time often than pressing.
Yeah.
But hand finishing these press restorations is no small task for a technician. You have to have a technician that is up to that.
Absolutely.
And that seems, is that a challenge to find?
Easy to find.
Is it? Yeah, can you
technicians?
The technicians that can do this.
That have the skill set.
Yeah, I'm using a couple of them, and they are able to do it. Of course, I don't know what about the technician, the ability of the technician.
Yeah.
But of course, it's challenging. That's for sure. That is maybe not the limit, but the you know, that you have to be conscious that can be dangerous because, of course, they're very, very thin. 2 days ago, before coming here, it was Monday. Monday was, we have checked the thickness. It was a really ridiculous thickness. We did it anyway. We feel very confident. I tell you, I have a lot of, I should just 10 rehabilitation. I can shoot 100 done in the last few years, 10 years. I tell you, I don't want to say that because it seems to be crazy.
Yes. But it's working.
It's working.
It's working, though.
Works just great.
So
Speak to the book a little bit about what's in that particular volume there. That's volume 1 of 2. And talk a little bit about the book and what maybe someone that purchases this book and is going to see and what they're going to get out of it.
Yeah.
It's a long story. The book came out in 2004. And actually, I was just using this aesthetic checklist myself. It was not so nice done, but it was a piece of paper.
Okay.
But all these parameters were written there. I was signed anyway in the wrong copy, in the bad copy, not beautiful like that. And then from this, I wrote the book. Not the opposite.
Okay.
Everybody believes that they wrote the book and they put this in the end. Not at all.
Okay.
It's the opposite. I just used in my patient day by day. Because if I don't do it, maybe some parameter will, oh, I forgot to put this. Oh, what about my line? Oh, what about my corridor?
Yes, right.
So
We're all
that's
the
the way.
same. Yeah.
That's the reason why I believe we had so incredible success. I heard, I mean, Christian has told me, after 10 years, the book is out if you don't do any change, blah, blah, blah. That is out from the last 16 years. Still producing, still asking China and Russia to have it.
Yeah. And this has all gone into the app, I would think, right? All of this same checklist?
No.
No.
It's not
Okay.
identical.
It's not.
We put more things in the app.
Okay.
Comprehending all the functional aspects. All the dynamic parts. It's difficult to say, but all the knowledge are in the app. All the steps, the the way how to arrive there isn't the app. So you have the green, yellow, and red line. And when you have on the red and the yellow, you have the alert say, look, no, go ahead because it's wrong. So it's, I shouldn't say, but it's fantastic. I think that we did an great job. I did that with my associated. We have in education, Fradeani Education, with me, Leonardo Baccherini, Roberto Turini, Stefano Gori, and Tiziano Bombardelli. All together, we have been working for a lot of time to produce that. And we believe that it's just great, but what we found at the beginning, great interest, because I present in the Congress in the States and all around the world. And then when it was the moment to say, okay, some way you want to join together, because for me, I spent a fortune myself, but then I cannot buy other systems, that the 3D systems to software, special software. So I had the chance to say, maybe we can have the chance to work with other people, other companies. And the company said, this is great, but it's too much.
Interesting.
Even, even big companies.
Right.
Wow. Because again, this is so if someone wants to learn, you mentioned your institute, where can they go to find out more about how to, because obviously you mentioned these techniques they're not simple, they are complex in terms of, say, the preparation design and the treatment planning. Where can they go to learn about your institute?
Oh, where or what?
Yeah, well, where can they go? Is there a website?
Oh, website, of course.
Yeah.
We have a Fradeani Education website.
Okay, Fradeani Education. Is it FradeaniEducation.com or?
You know what? You ask me something wrong.
Well, that's okay.
Something difficult. I have people working on that.
Yes.
All day long.
But if they Google that, they'll find it.
Yeah, you have to Google.
Okay.
Go to Google. Yeah, the website.
Yes.
Of course, you can find there.
Very good. Very good. Well, we really appreciate your time, being with us today.
Thank you very much.
And what you're doing, obviously for the profession, not only pushing the limits and finding where those limits are. The companies are obviously responding to that, but then also, providing these checklists, these frameworks that we can use to make our dentistry better. And thank you very much for spending time with us today.
Thank you.
Thank you
very much.
So if you're listening to this right now and you liked what you heard, I think, John, the first thing I would say is subscribe to the Dental Guys.
Right.
We're on YouTube. We're on Facebook. We're on Twitter. I think I put out some stuff on Instagram regarding Dennis Tarnow's lecture recently about taking implants out that are placed too facially, how he would approach things now. So we're going to have some up-to-date things about the Academy of Fixed Prosthodontics meeting as it's going on right now. But if you want to learn more about where these books come from, we appreciate Quintessence.
Yeah, check out Quintessence, and so many good resources, and you can learn more about what Dr. Fradeani is talking about today, as well as many other authors. So for Wes, I'm John, and for Dr. Fradeani, we are the Dental Guys. Okay.
Done.